We are live and you can start, sir.
Oh, great. Just to the stopwatch. Um, Good morning, everyone. Thanks very much for the wonderful opportunity. Dr. Anandaraman and Dr. Santosh and the whole team of Magna. And thanks for the chairpersons for chairing my session today. So the session is for next 20 or 30 minutes or so. The topic is to drive home the message about the basal glargine insulin, which is like a gold standard insulin that has been there for a while. But how redefining the insulin therapy in the landscape of treatment in over the past 2 decades in India. Now, the important aspect is it is a company talk what I'm doing today. It is for Sanofi and a honorarium is from them. But I think the concept of basal therapy has been evolving over past probably past decade or so. In India, it's gone up in a big way and it's taken off. I'll show you the data, how it has changed the landscape of the insulin therapy, how people's attitude has been changed from premixes to basal insulin as insulin initiation, and how simple the insulin initiation has become. Previously, thinking about insulin means, oh, it is a big thing. Now we need to refer to a super specialist and specialists like forth. But now I think a lot of general practitioners and physicians, quite a lot of them are starting with ease. Even you can see the junior doctors are starting the insulin initiation as really an easy way to do. Um, it is to do with the education in a lot of conferences. The insulin initiation workshops and other things are going on. But even though the contribution of the science in this area has moved forward, so that the basal insulin has been started, made it very, very easy, so that the landscape has changed. So with that introduction, I'm just going to talk with a clinical scenario. We got a patient which we face up in the clinical setting, hyperglycemia, very bad hyperglycemia, and this patient is on 3 OADs. So for example, the patient name is Mr. Ashok, he's 45-year-old and diabetes for almost 3 years. And then he presented to diabetic clinic for a routine follow-up. No history of hypertension or heart disease. Current BMI is 27. And also he's got ophthalmological examination wise mild non-proliferative diabetic retinopathy. HbA1c is about 8.8 as the fasting blood sugar, and the postprandial blood sugar is way above 200. So as I mentioned, this patient is on all triple therapy already. So metformin 1 gram BD and sulfonylurea and also a gliptin. So all three drugs are there. And a second clinical scenario, a long-standing diabetic again, the patient name is Ramya, and almost 10 years of diabetes, but peripheral neuropathy is present with burning pain and numbness in feet. However, there is no hypertension or heart disease. If you look at the blood pressure, it's quite normal and not tachycardic or anything. The weight is average, but the EGFR is in 74, but mild microvascular disease indicated by non-proliferative diabetic retinopathy. So as I mentioned, the control is very, very bad here for Mrs. Ramya as well. So look at the fasting and PP, both are above 200. That indicates clearly that 9.2 is the A1C. Now look at the gliptin and metformin is two drugs, and then the glimepiride is third drug. Now these three drugs are the commonly used up drugs. However, now the SGLT2 comes into play, but AGIs are not that much used, and pioglitazones not that much used. So these are the three common drugs that we see in a practice: metformin, sulfonylurea, and gliptin. So three drugs are there for a patient, one and two. What would you do next? I know my topic is insulin related, but why insulin? And that is the key point that I want you to take as a message from this talk. Now, doctor, why can't, I mean, we do three drugs and patient would be much more happier if the insulin, the needle is not there. Why can't I go for the fourth drug? I can just add on a OAD or of some sort, like a pioglitazone or anything. But what is the difference? See here in this data, you can see when you add on a third drug, in addition to the third drug, if you add on a drug, there is no change in A1C compared to 3 drugs or 4 drugs, and that is the challenge. Unless you missed out the complete pathology of the disease and went into the wrong drugs initially. Other than that, I think the data showed only 0.3% A1C reduction in both arms. That is shows that there is no statistically significant effect when you change the drug, when you add on the drug. Sorry. So you can ask me. So fourth drug, you said that is can't be added or no need to add because there is no benefit to it. Why would you consider insulin? If you look at the meta-analysis of a DPP4 inhibitor trial, 52 weeks trial, the A1C slightly got getting deteriorated after some time, and that is one thing with the DPP4. And if you look at the DAPA study, after 2 years, the efficacy is becoming slightly less. Same thing is observed with all other SGLT2 trials. So indicating after certain time, the drug inertia happens, and the drug failure, if you like, even though it's not the mechanism that is fully explained, but looking at it, these data, the efficacy of the OADs is definitely reduced. This is published in 2018. Now, why to consider insulin in these patients? Because if you look at the statistic landmark trial, that is the one trial that I'm going to talk a lot today in this talk. uh, zero point 0.3 A1C reduction in a patient with insulin naive, that's not having insulin. However, when you start having insulin, in this landmark trial particularly, um, there is 0.6% reduction, which tells you almost there is a statistically significant of p-value of less than 0.01. So landmark is a trial which is like a longitudinal nationwide study in the management on real world outcomes of diabetes in India. Like diabetes in India has been not much more, if you like, the practice is not being evaluated in a big clinical trial, but this is one of the landmark trial. So landmark is named after landmark, showing that the data is so robust to say that insulin starting will be a beneficial thing in the real world setting. This is real world data. So which insulin to start with? So now we are clear. Third drug is there. Adding a fourth drug is not an option because there is not much of benefit. So we are adding on insulin. That much we are sure with landmark trial. Now coming to the point where what insulin is you're going to initiate. As I said initially, the DiabCare study in 2011, if you look at it, the pre-mix insulin is in the orange bar, which shows a huge thing difference of a 52.7 was predominantly used in India. In the decade or so, what happened is, see the next graph. Why before that, I want to show why the premix insulins are very if you like, more popular in India. It is perceived that that will control the postprandial sugars really well compared to the basal thing, and the premix will provide a better glycemic response compared to the basal one, and that is perceived number one. And number two is the high carbohydrate in Indians has made the PPG to go up, and the premix will work better as is another concept. And another last concept is like FPG and PPG are managed both very well with the mixed insulin, and that is the concept of perceived reasons that why mixed insulin was popular. However, that has been changed in the last decade or so. 10 years down the line, past 10 years, you can see the base insulin percentage was initially in the DAPCAR studies only 13.8%. Now look at the data in landmark trial, a huge whopping 53.6% of proportion of insulin receiving patients started on basal insulin. As I said, the reasons to it is good knowledge and science spread across this area. Number two, easy usage. Number three, I think the doctors are very confident in using the basal insulin as just one-off thing. And the last one is, over the years, the doctor's personal experience has made them to start basal insulin very, very fast. So this is adapted from landmark trial. So my way today is going to be three reasons for a paradigm shift. And you know that we, after three drugs, fourth drug is not an option. And we decided with insulin, and we said that mixed insulin was popular in India, but it's changed into the basal insulin. Why? And these is the three reasons for a paradigm shift that has happened. And you should know this science. So this is the main science that I want to drive across for today. If you can remember this slide, fixing the fasting first, because fasting, the mechanisms are huge: hepatic glucose output, poor control in the fast, and the overall glycemic memory all contribute to the fasting thing. And then the holistic glycemic control makes a huge difference in terms of reduction of micro and macrovascular complications. And the efficacy, of course, you need to be having an efficacy of the drug and the safety data to make sure it is being used for a very long duration. Now, let's start with the first one, which is called fixing the fasting first. Higher the A1C, greater the fasting, which we know that very, very for a very long time, that if the A1C is higher, the fasting sugar is very high. So look at the fasting blood sugar, which is the blue line, which is contributing a lot for the A1C. And the bars goes from 6 to 6.9 to about 10%. You can see the bar size is increased with the blue one, which is the fasting one, is contributing a lot for the A1C. So we need to fix the fasting first. The FBG with more 7 than millimole is more of a European, it's a millimole description, but if you look at it, it's almost 126 milligram per DL. So if you have a blood sugar of more than fasting of 126 or so, what is the data tells us? It's an independent risk factor of mortality in patients with COVID. So the patients who are admitted with COVID disease, if you have a fasting blood sugar more than 126, the high chance of mortality is there. The mortality rate is 2 to 3-fold increase in the mortality. So you know that now, that we all know that bad blood sugar is not good for COVID. But above 126 in the fasting state puts you the very, very high risk of getting mortality with COVID. So whatever COVID is a very unpredictable disease. We are all scared of about it, and there are a lot of things that we can't do to change the progress of the disease. However, I think if blood sugar is less than 126, you know you're less risk compared to somebody who is above 126, and that puts them almost 2 to 3 folds high risk of mortality. So as I said, the COVID positive patients are high risk if more than 126 deciliters of blood sugar. So what is the relationship between fasting blood glucose and the risk of being admitted in ICU in COVID-19? I've explained very clearly. Even the small increase within the normal range of fasting blood glucose may be associated with a very high risk of ICU admission in patient with COVID-19. What in the previous slide I showed is the mortality due to COVID is very high when the fasting is more than 126. But now I'm saying the ICU admission rate is high when there is even if you tell doctor 80 is a fasting, 100 is 120 is a fasting normal range. But which one would you like? You want the lowest one, because even the small increase within the normal range itself, the fasting will make the patient to go on the risk of ICU admission. It's almost 15-fold increase. That is a phenomenal amount of fold of increase when you get a poor sugar control to get into ICU. So glycemic target achieved by glargine 100 despite a high baseline A1C. This is like That's the data, almost like 2 years of data, by 2003 by Riddle and 2005 by Janka and Gerstein. Herschel Gerstein is a guy who's done a lot of inpatient work. He's from Canada. And then 2008, Brett Selwan and Matthew in 2015. So there's so much studies have showed insulin glargine attain the fasting normoglycemia. Therefore, the whole A1C is reduced. The glycemic target is really a good one with the insulin glargine. These are the big studies that showed that. However, personally, you and me using glargine for more than almost 15 years or so, we know it's a beautiful drug that works really fixing up the fasting and therefore the whole A1C as a whole. So I mentioned, I want you to remember this slide. I mentioned and I spoke about fixing the fasting first, and I've given the evidences to show how the basal insulin does it. But next one is the holistic glycemic control. So I mentioned about the fasting, but how about the PPG? What happens is once you fix the fasting, if the blood sugar is 140, for example, and you're fixing it to 100, so when you start eating with the blood sugar of 100, there is a high chance that it will go only up to 180 or 190 or 170, something like that. However, if you start with 130, then it goes about 200. So if you fix the fasting first, that the postprandial blood sugar excursion will be much more lesser. So elevated fasting hyperglycemia is the biggest challenge. And if you make it normal, what happens is that PPG comes down very, very nicely. So this graph would have shown you very nicely that if you get rid of it, the sugar comes down in PPG very nicely. So it is called fixing the fasting first, which we done in the last bit of my talk. Um, the last few slides before in my talk. So the basal insulin provides it's a holistic glycemic control in real world scenario. This is the landmark trial. Again, I'm coming to. It shows that almost 6 months of follow-up with the fasting and PP, both PP you can see 228, the blue line. It shows the baseline one, and 6 months later, it controls really well 135 and 190, which is statistically significant after basal insulin. So we want to target the fasting normoglycemia, and therefore the PPG will be perfectly controlled. So the mean 2-hour PPG level decreased from 12.07 plus or minus 1.17 to 8.94. That is quite significant statistically. So these two I've discussed already, fixing the fasting first, and you have to do the holistic glycemic control. How about the efficacy and safety? I'll come to that in a minute. So if you look at the pink one, which is the glargine, and the premix one in the blue one, you can see there is a head-to-head comparison of glargine 100 with premix analog for the efficacy wise. On the other side of the bar, that's a percentage of people achieving the A1C below. So in the pink one, which is the glargine one, attained almost 43% attained the target compared to 12.5 of premix one. That tells you clearly the A1C reduction is quite good, and it shows almost 20% greater A1C reduction in glargine A100 compared to premix. That's a huge A1C reduction compared to the mixed insulin. The lower hypo risk is another thing. So with the basal insulin, we are not having any mixed insulin all over. The risk of hypoglycemia and the risk of weight gain is much, much lesser compared to premix insulin. So the lesser risk of overall and nocturnal hypoglycemia with glargine plus OAD compared to human mixed insulin. You can see in the blue one, which showed 13.3% of hypoglycemia compared to 2.85 of the glargine one. Again, I mentioned about the weight. So the weight gain is also much lesser than the basal insulin compared to the mixed insulin. Almost 50% of lesser weight gain in glargine compared to, that's a huge volume, 50% less weight gain. And doctor, you mentioned about comparing glargine with the mixed insulin. How about glargine versus co-formulation, which is like the Rysodec, which is like basal insulin along with the short-acting one. The A1C reduction is almost comparable, and the fasting is almost comparable. But I think the fasting is much better in the basal alone group of drugs. So the glargine 100, which is co-formulation, and the safety, almost the weight gain is almost 36% less in the Lantus arm compared to the Idagasp arm, so which is like a Rhizodite. So I mentioned about the three things, that is fixing the fasting first, and then glycemic control, overall holistic glycemic control, and also about about the overall control has to be good. Now, coming to the global, how about the global guidelines? The guideline shows the basal insulin premix, which can be started either way, which can be started in the even the 2012 guidelines compared to the recent one, uh, that premix insulin is out of the guidelines in the ADA 2021. They say just as a simple therapy, you really need to go for basal insulin. So, and the guidelines have changed a lot from 2017 to 2021. All the time the basal was there, but the premix one has been taken off from 2016, 14, and to 14 respectively with other bodies. So it is the trend of the clinical practice that has moved, and the science also moved along with it. I have to say the other way around: the science moved and the people moved along with it, and henceforth the guidelines is also moved in 2021 up to that. So again, coming back to COVID-19 pandemic and the Indian expert panel, they say basal insulin analogs are the simplest way in people. Uh, Initially, the COVID was managed only in particular hospitals. But what happened is when the volume increased and increased, a lot of peripheral, small hospitals have started catering for the COVID patients. But the challenges with the steroids, the sugar shoots up, and those doctors who didn't have much of experience, they all started with the basal insulin, which is the amazing way to start insulin, and the control is very smooth. And the starting dose of the basal insulin is either 10 units or very slow dose of zero point 0.1 to zero point 0.2 units per kilogram per day. So this is what has happened during COVID time and still happening with a lot of doctors. So my last 20 minutes or 25 minutes or so, the initial introduction, what I've given is about the where is the change that has happened recently. So the three drug, I've given two case scenarios to say that uh, three drug combination is there in the patients with poor control. What do you do next? And I've also explained with a lot of science saying that adding a fourth drug, it doesn't bring any difference in the HbA1c reduction. So therefore, and you notice all the people are on OHAs, the potential action and the worsening of A1C becomes very prominent if the patient stays on the treatment of oral OHA for a very long time. So insulin initiation was the best one that has been noted. So that is the second point I brought across. And after noting that insulin initiation has to bring, the third point is to save which insulin. And I've also shown the data showing that how in the DIAP study, initially that showed mixed insulin was so popular, and in now the recent landmark study showed basal insulins are a whopping more than 50% has been taken. So I've explained the reasons for why basal has been picked up. Simple injections and effectiveness, and also the safety. All these three things made the basal insulin to be taken off by the clinicians very swiftly. And then I brought in the point across saying that the basal insulin has to be having fixing the fasting first, and making a holistic glycemic control, and making a drug which is effective and safe. So I went through each with a landmark trial and fixing the fasting first, and also about the safety of less hypoglycemia and less weight gain through data. So To conclude, merits of glargine 100, which we've been using for almost more than a decade, is more physiological, efficacious, and in COVID conditions more than 126, we can fix that so that the chance of them dying or chance of them going to ICU will be less. And it's a simple and convenient regime. We can fix the fasting, and that in turn reduces the postprandial, and that in turn reduces the A1C. So this is the preferred drug during the COVID pandemic, and it's supported by the local and international guidelines. I'll stop there and hope that I brought in the message is very clear that basal insulin is much more safer and efficacious. Thank you very much for the opportunity. I'm happy to take any further questions. Thank you.